Hi, everyone. This is Marie, Executive Director of Adonis Fertility International, and we are here today speaking during our Hot Seat Wednesday with a phenomenal guest, Alie. Alie, hello. How are you?
I'm good, thank you.
I'm so excited. I didn't use your title specifically, and I didn't name your company because I really wanted you to make your introduction
Sure.
and kind of tell a little bit story about how did you get even into the field. How long you've been with the company, and also I know that you kind of fulfilling, a role with different hats.
I don't see it in this chart, but give me 1 second.
Sorry, guys, I'm gonna mute. Thank you so much. All right.
All right. Thank you so much, Maria. So my name's Alie Corirossi. I'm a lead genetic counselor and medical science liaison with GeneScreen Genetic Counseling. So just to give a little bit of background on myself and how I got into the field of genetic counseling. So I actually became interested in genetic counseling more on the hereditary cancer side. So I have a family history of cancer. My mom has met with genetic counselors in the past to do genetic testing based on her history. So that has kind of always intrigued me. And I actually didn't know much about the field. I knew about genetic testing for hereditary cancer, but didn't know much about genetic counseling itself. And I was actually just listening to an episode of NPR, and they were talking about fields that were, expanding, where there was a lot of need and a lot of demand. And that's actually how I learned about genetic counseling as a field. So initially, when I, decided I wanted to go into this and started shadowing and applying for, my master's program, my initial intention was to work in hereditary cancer and sort of pursue that specialty. And I sort of, found fertility, found preconception genetic counseling sort of serendipitously when I was looking for a job. And I just absolutely fell in love with doing it by working at GeneScreen. So I've been here now for about almost 4 years. So, my current role, I started just seeing patients full time. In my current role, I'm a bit more hybrid, so I still see patients because I really enjoy seeing patients. But additionally, I sort of work as again, a medical science liaison between the clinics and the practices that we work with, and with our genetic counselors, just to sort of facilitate some of those operations.
Okay, okay. Thank you so much.
Mhm.
We never want to make assumptions how much people know about genetic counseling and everything. And you also
Sure.
said that, the reason you got into it because it was one of the fields that it was intended to be noted to that it will be expanding and growing, which
Mhm.
it is. Let's start really with the basic. Bring us to the common denominator. When we talk about genetic counseling, what are we
Mhm.
looking for? What are we looking at? And we specifically talking about genetic counseling for the purposes of the fertility, okay, of the assisted
Yeah.
reproductive technologies, right? Whether you use
Mhm.
the surrogacy program with egg donation, right, or with your own
Mhm.
embryos, whether you're creating embryos, not just egg donation, right, or you looking into sperm donor, anything, or you using then for the purpose of IVF.
Mhm. Yeah, so I mean, just to start, I guess really the purpose of genetic counseling during this process, or the role that a genetic counselor can play, is really to provide support to the individuals going through this process. Our job, our goal is to provide information and education to really empower individuals to make the decision that is best for them and their family planning. So our goal and our job is never to tell somebody what they should do, how they should go through this process, what kind of treatment decision they should make. Our goal, again, is really provide that information, answer questions, and really empower patients to do that for themselves. So we may make recommendations, we may say, based on guidelines or based on your specific history, we're going to take all of this information, maybe make a recommendation, or maybe discuss various options. But ultimately, that decision is meant to be up to the patient, up to that individual going through it. So really, we're meant to kind of assist in that process and provide that support. Um, So I don't know if that really, if that sort of
No,
answers your question, but
that's absolutely perfect.
yeah.
And then the scope, so like genetic counseling, the reason I'm also asking, like,
Mhm,
outline the scope. I know that sometimes when families comes and they would say, well, we already have done, genetic testing, we don't need to do anything else. But a lot of times they're thinking about pre-implantation genetic testing for their embryos, right?
mhm,
Just that. It doesn't,
yeah.
go and look in everything, like you're saying, the scope and information and data that goes with every person. Uh,
Mhm,
or sometimes people are confused in saying that, we're doing something during prenatal screening.
mhm,
So perhaps it will help also to understand the scope of genetic counseling, maybe what phases they would come, or would it
mhm.
be at any time? So, yeah, so help us understand that.
Sure. So I think you touch on a good point that there are many different types of genetic testing or genetic evaluation that someone may go through with ART, right? Going through this process. So there is preconception genetic testing that could be important whether someone is, an autologous couple or whether someone is potentially using donor gametes. Preconception genetic testing would be, for example, expanded carrier screening, which many people may have heard of before, but that is done, as the name preconception implies, before conception. So that would be done ideally before embryos are created or before pregnancy, depending on an individual's situation. And this could be indicated whether someone is going through fertility treatment or not. But this is, indicated really for anyone who is planning to contribute gametes to a pregnancy. So planning to contribute their eggs or their sperm to a pregnancy. So with the expanded carrier screening, the goal of that is to identify individuals that have an increased risk to have pregnancy or a child affected specifically by an inherited autosomal recessive or X-linked condition. So
Mm-hmm.
those are the two main inheritance patterns that will be covered on expanded carrier screening. Just, I don't want to get too in the weeds, but just to kind of touch on that with the recessive inheritance, those are conditions, for example, some common examples people might be familiar with would be like cystic fibrosis, sickle cell anemia, for example. With those conditions, we need both the sperm and the egg source to be carriers to have that increased risk to offspring. So
Mm-hmm.
again, whether someone is, an autologous couple or using a donor, identifying that increased risk could be helpful in determining potential treatment options. If someone is higher risk, they may decide that they want to go through IVF and that they want to test embryos specifically for that condition. Other individuals may not want to test embryos. They may be comfortable with the risk presented to them, and they may choose, not to do any pre-implantation genetic testing of embryos. They may choose to do prenatal testing, or they may choose not to test at all until a child is born. So really, there are many options, but that's kind of where genetic counseling would come in at that point to sort of help patients determine what are my options and what is the best choice for me based on the information that I'm being given. X-linked conditions are also typically screened on carrier screening panels. A common example would be Fragile X syndrome, for example. With those conditions, we actually only need the egg source to be a carrier for there to
Mm-hmm.
be that increased risk to offspring. Um, and then knowing this information in the context of third party, so using a donor, knowing this information can really help identify a donor that, would be appropriate or would be a good fit based on your needs.
Thank you so much. I
Mhm,
think this is really helpful, guys. Again, like because I know so much terminology is being thrown at us, and a lot of times, especially if you're going through like fertility journey, right? I think many times parents would say that it feels like drinking from the fire hose, right? And that's why we really grateful that you're spending time with us and a little bit like opening the window and saying this is what our field does. Um, Sometimes I hear that families feel that anything with the word counseling, genetic counseling, psychological counseling, specifically for ART, psychological evaluation, this is more like, okay, there is a check mark that we have to do, but we don't really understand like how much value would it add to us? So if I'm a person that is looking at the process, the timeline, funds and everything, and saying, well, do I even need, like, I don't think anything is with my family, or maybe, yes, I know something is in my family, but none of us have gotten it. How would you tell them, like, why do you think that conversation is important, first of all? And
Mhm.
second, what would they expect from your session?
Yeah, I think that question is twofold. I think there's a couple points. Something that I always like to clarify when I do meet with patients and sort of explain, kind of going even back to the last question that we talked about, right? I think there are a lot of misconceptions about genetic testing, the different types of genetic testing. I often get asked, and this is a really valid question. I often get asked, well, we are planning to test our embryos. So wouldn't they already be screening my embryos for all these conditions that I was tested for?
Excellent. I'm so glad you bring
Yeah.
that up. Yeah.
Yeah. So that's a very common question I get. Perfectly reasonable question, but patients just aren't necessarily informed about what it is that is actually being screened. Let's say they choose to do pre-implantation genetic testing for aneuploidies or PGTA. So this is a common type of embryo testing that is offered sort of across the board. Every clinic's a bit different on when they offer this, but it's something that may be more routinely offered even if someone has, low risk carrier screening results. The reason that this testing is offered is actually to screen specifically for aneuploidies. So chromosomal abnormalities, maybe there, is an extra or missing chromosome, or there's a large piece of a chromosome that, is extra or missing, right? So those, while they are genetic alterations, they are typically not hereditary or not inherited. They're occurring sporadically, randomly, and they're not something that's actually being passed on from the egg or the sperm source. So really the goal with that testing is to look at the amount of chromosomal material present in the embryo. Now, granted, we're only testing a couple of cells when we're doing this kind of testing. It's not diagnostic. It's just a screen. But the goal is to try to help us identify which embryos really to prioritize for transfer to give the best chance of successful implantation and ongoing pregnancy. It is not designed to test for these recessive, these X-linked conditions, or other inherited conditions. So I think that is one of the most common misconceptions that I dispel when I meet with patients. Um, I think oftentimes we don't know what we don't know. And again, like you said, there is so much information. There's no way that you can consume it all and digest it all. So I find that, patients really benefit from having these genetic counseling sessions because even if they are incredibly educated on the topic. Many patients have done a lot of their own research, which is fantastic.
It
Then they
is.
can come to this session and they, have this background, they have a base of information, and we can kind of just dig deeper and dig further. And then they have the support of somebody who does this, day in and day out to kind of help them process this information and identify what it is they're looking for. Every patient, every couple is different and is going to want something different out of their session. And that's okay. Our job is to tailor your session to you. So typically the kinds of things that we would cover, because I know you kind of mentioned that, we would typically cover any genetic testing results if testing has been performed. Primarily, the kinds of things we're seeing would be carrier screening results. We may see a karyotype or chromosome analysis performed on an individual. Sometimes individuals will come to us after their embryos have been tested and they want to review those results with us. And then additionally, we will generally go through patients and or donors' family histories as well and sort of assess how that family history impacts, that reproductive risk assessment. So that's usually what our sessions look like. But again, that can vary depending on the reason for the referral or why a patient is seeking,
Okay.
genetic counseling.
Okay. Okay. Absolutely makes sense. And so then, another question I have is, once they have those results, do you, or, if there is something finding how do you then help them make decisions? Or, is there is more data you're bringing, or maybe some questions where, they're on the verge, you're saying we're always more like informing, but ultimately it's up to them. Is there something that you would say, like, it's highly recommended, or here is some risk, please hear us? How does it work even on the human side?
Yeah, so I think it kind of depends again on what the recommendation is, which I know is not super helpful. But if there are guidelines that tell us, okay, here's a recommendation that we're making, if there are guidelines to sort of back that recommendation up, we will often reference those guidelines. Just I think it's helpful for patients to know where that's coming from, why we're making that recommendation. Um, Beyond that, though, in sort of helping that individual patient decide whether, maybe additional testing is recommended and they're having a difficult time deciding whether that's something they want to do or not. I think it really just comes down to exploring with the patient what they're looking for. For example, if you chose not to do this additional testing and you ended up having a child that was affected with this condition. Is that something that, that you're potentially comfortable with, right?
Mhm.
Not from a place of judgment or from a place, there's no right answer to that. And oftentimes patients will say, well, it depends on what the condition is, depends on, how much extra time this may add to, my cycle or to my process, how much of an additional cost there is
Mhm.
because obviously that's a big factor and sometimes a limitation that, limits people's ability to potentially do testing that maybe they would otherwise want to do. Um, so usually there are a lot of factors that kind of play into that. So generally it's just picking apart those different factors and sort of assisting a patient to determine again in their specific situation what they're most comfortable doing.
Okay, thank you so much. I know you're using the term patient, right? But
Mhm,
I also know that you're not working, or maybe you're referring to both sides as patient, but to
mhm,
us, typically patient, it means intended parents, right?
mhm, mhm.
However, I do know that you also work with donors. So how would that be different, your support and the sessions that you're having and what you're looking for? Mm-hmm.
Yeah, yeah. So certainly, yes, we do provide genetic counseling for donors. I apologize. Generally, we refer whoever we're meeting with, we refer to as our patient. But that could be donors, that could be intended parents. Could apply to really anybody that we're meeting with. And generally, when we're supporting donors with genetic counseling, again, it can look kind of different depending on where in the process the donor is in their journey. So that may be consenting them to genetic testing. Maybe they haven't had testing yet, and we are explaining the kind of testing they will be having and ensuring that they understand what those results could look like, what that could mean for them, not just in their journey of becoming a donor, but also potential future reproductive implications for themselves. I know many times donors are, they may not be at a place necessarily where they are trying to build their own family. They are focused on donating their gametes. So oftentimes, that can be the focus of the sessions, but we also want to make sure that donors understand, again, any implications there may be for their future reproduction. So really just kind of educating them on any testing that will be done for them, or if testing's already been done, again, reviewing those results with them and explaining what this means for the donation process as well as their own reproduction. Um, and again, generally a family history risk assessment is going to be a big part of that. I would say in general, our sessions with donors are certainly more focused on the donation process. Definitely just because of where they're at. But again, we're there to support in any way that we need to and make sure that they're educated on what it is they're doing now or when it does potentially become applicable to them in the future.
Okay, okay, thank you so much. You also mentioned, well, I mean, because it is a growing field, and we know just in science, and especially in assisted reproductive technology and the field of genetics and so forth, there are so many things that are developing at just rapid speed, right? And
Mhm,
is it something you're noticing in genetics? Is it the correct statement to say that there is more methodology coming, or the way there is more data coming through, right? On the cases that
mhm,
are coming through assisted reproductive technologies, through the third-party reproduction and so forth. How then that adjusts your counseling? Example could be, for example, there has been a donor, right, that has been used successfully for several families, or maybe
mhm,
the donor oocytes or gametes, sperm has been frozen. Then what? Right, and everything is going well, but then there has been cases reported, or maybe
mhm,
some conditions. How is that feedback loop works, or how then you and your team continue staying on top of all of those developments, and how then
mhm.
informing the patients who may be in the process.
Yeah, that's a very good question. Oftentimes, the process of informing individuals is sort of managed or monitored by, in the case of, let's say there's a donor, like you mentioned, and there are potentially multiple recipients of that donor's gametes. Um, and then there's some sort of, adverse outcome in one of those donor conceived pregnancies. Generally, the notifications are oftentimes handled by that donor agency themselves, but oftentimes they will pull us in. So we are independent genetic counseling providers. So oftentimes we will get pulled in to meet with either that donor, and sort of review that adverse outcome with them, because sometimes we don't always know. It could be, maybe someone was born with a birth defect, right? And maybe it doesn't really have super significant implications for the donor or any other, offspring of the donor. It's possible, though, sometimes, there have been situations where additional family history information has become available for the donor, that has actually led to additional genetic testing being performed and, a genetic syndrome being identified in that donor. So really, depending on the situation, that may mean that, it's helpful for us to meet with the donor themselves to sort of review that information and what it could mean for them, but also any other recipients of that donor's gametes as well, and what that could mean for any existing offspring they have from those that donor's gametes, or if they have, the intention to use that donor again in the future, what that could mean for future offspring. So really, our goal would be to support essentially every party in that situation, regarding, explaining that information, next steps, if there are next steps, right? If additional genetic testing is something that would be, beneficial or useful in sort of clarifying that reproductive risk.
Okay, thank you so much. And I'm so
Mhm.
glad you're having that feedback loop. I think it's very important.
Yeah.
Another thing, because you mentioned carrier screening, right? And I know families sometimes they coming with the carrier screening results that are, I would say the panels, that are very different. Do
Mhm.
you feel like, tell us a little bit more, like, is there an agreement on which panel should be used? Is there a wide variety? Or if people are looking what are like, what they should be, maybe guided by. Some
Mhm.
families, for example, they more like an individual journey, right? There is no, maybe agency involved that also could lead them, or they're looking into different doctors, they're making some decisions. What would you
Yeah.
say, guys, like when you're looking at the carrier screening, here is at the minimum what we recommend, right? And like that.
Yeah, that's a very good question. Oftentimes, the conditions that are included on carrier screening panels are not necessarily um, super regimented, if you will. There are so many panels, so many size panels, right? So, the American Society for Reproductive Medicine has guidelines recommending it's around 120 autosomal recessive and X-linked genes that they recommend anybody who wants to contribute, gametes to a pregnancy be screened for. Many panels are much, much larger than that, than that size, and they may or may not contain all 120 genes. So generally, we oftentimes may not be able to find a panel that does include all 120 of those genes. Oftentimes, we're more guided by, what type of panel, if someone is using a donor, let's say, if they know where their donor will be coming from, what agency their donor will be coming from, we often try to recommend a concordant or matching panel to avoid discrepant results.
Mm,
Sometimes discrepant results are inevitable, and we will, of course, address that when needed. But something that we see happening fairly frequently, especially in recent years, as there has been a lot of shifting in the lab industry, the genetic testing lab industry. Something we see much more frequently is an individual coming to us. They've had carrier screening done, whatever the standard panel is, maybe at their fertility clinic. They've often had that done, and then they select a donor from, an external donor agency that has had whatever panel is the standard for that program, and they're not the same. And that's not always a problem. When it becomes a problem is when one individual is positive for something the other has not been screened for.
mm.
And again, it doesn't mean that additional genetic testing can't be performed, but it's not ideal, right? Because it's an additional cost, additional time.
It is. And usually pulling out one specific, you would think like, panel
Mhm.
is more expensive than one specific one, but it's actually not. It's the other
Right.
amount.
Right, right. And sometimes it's hard to find a lab that will do, test for that gene depending on the gene. So generally, if someone's coming to us and they haven't had any screening, and they know where they want to use, what type of donor they would be using, we would generally do our best to try to match those panels. Um, or at least explain to them the limitations of not matching those panels, that there is the possibility that we could get some discrepant or discordant results. But some patients, they're comfortable with that and they want to do the largest carrier screening panel, on the market, even if that means there will be things that they're positive for that a donor hasn't been screened for. So really our goal is just to kind of walk them through the possible results, the possible outcomes. And as long as they're comfortable with that, again, we'll make our recommendations and provide guidance. But ultimately, our job again is really to, just provide that information and empower patients to do what feels best for them.
Okay, thank you so much.
Mhm,
Do you mind sharing maybe what was the reason for the 120 recommendation? Is it like other conditions that are more often and because you were saying that it's American society, is it
mm,
when the looking cases is saying if we have deviations, this is 120 that I've seen the most, or are there
mhm.
conditions that are the most impactful? Like, how is it even being determined?
Yeah, that's a good question. There are kind of a couple of factors that go into that. So it is, frequency, how common the carrier frequency for those conditions are, sort of, pan-ethnically or across the board. Also, age of onset. So it's really going to be more focused on childhood onset disorders, less so on adult onset disorders, which I know there are definitely adult onset disorders that sneak into a lot of these carrier screening panels. But generally, that's not something that's going to be highly recommended by these professional societies. So yeah, frequency, age of onset, severity of the condition. So, more severe conditions may be more likely to be, recommended. Again, there's no one single comprehensive panel though that's going to be able to screen for all conditions. And that's something that I always discuss with patients as well, that even if you had the largest panel on the, commercially available on the market, it's still not going to screen for every single genetic disorder that exists. So I think that's something that's important as well for patients to keep in mind, or for individuals to keep in mind is, this is a screen. Our goal is to try to identify individuals at increased risk, but it's not a catch-all. It's not going to identify every possible risk or every possible condition.
Okay, okay. And that's why, then understanding the pathways and knowing, yes, there is pre-implantation genetic testing, then later, right?
Mhm,
So, like you said, you more talking about testing and screening that is more preconception, right? But there is
mhm,
conception and then, the prenatal screenings and like
mhm,
it all places the goal of the healthy child and,
mhm,
stress-free pregnancy. So this is very good. Another question that does come up, and I don't know, and please bring up like if there is some questions that I have not asked you, but you like, oh
mhm,
my God, like over and over, I see this misconception or I
mhm.
see these questions. Let's also share because again, our goal is to equip the families that are or
Yeah.
that are listening, and the parents, or if there is someone considering to be a donor. right? Anyway, so the question is autism.
Mm-hmm.
Is it something, right? Because there is such a huge spectrum. So
Mm-hmm.
if there is anything that is already where you supporting families, like I don't know, it just I know that I literally had some families that saying, well, we read so much about autism, we're just scared of that. So we want to make
Mm-hmm.
sure our child, like, how can we guarantee our child doesn't have it? Of course, our immediate question, yes, go talk to the counselor, right? Let them
Mm-hmm.
recommendations, but what about it?
Yeah, so with autism, it has been demonstrated to be highly heritable. So we do definitely believe that genetic factors play a pretty significant role in the condition. However, in many cases, a genetic cause actually cannot be identified. So even if an individual themselves is diagnosed with autism, and undergoes genetic testing for that, and there are many, many potential genetic causes for autism. I do want to note that many genetic syndromes where autism may be one feature. There are, again, many reasons why, and many of which are not going to be included on a carrier screening panel. Additionally, much of this genetic testing is something that is not necessarily recommended as predictive genetic testing, but would be recommended, more strongly in a case where someone is actually diagnosed potentially. And that's something that it would be recommended that individual meet with a medical geneticist or a physician specializing in genetics for an evaluation and determination of genetic testing and whether that's appropriate for that individual based on their case. But again, in many cases, even if someone undergoes genetic testing for that, there are many cases where we cannot identify a specific genetic cause. That doesn't mean that there are no genetic factors at play in that case necessarily, um, but it's something that we're still learning a lot about. And I am certainly not an expert in the genetics of autism. It's actually not something that we really do any genetic testing for or at GeneScreen, just because again, that is something that is generally done more on a diagnostic level under the care of a physician. So it's generally not something that we are coordinating testing for in most cases, but it is something that I get asked about quite frequently. So generally, if it's something where there is a family history of autism, oftentimes what we would discuss with individuals would be potentially an empiric risk assessment, if that's something we can provide based on maybe number of affected relatives or the degree of relationship to that affected person. But ultimately, that's something, we would generally say that that individual with the diagnosis would pursue a genetic evaluation. In cases where there isn't really any family history that's known or anything like that, generally that's not something, we're recommending any like predictive genetic testing for.
Okay. Thank you so much for
Mhm.
answering. Maybe it's a goofy question, but as far as the trend, for example, in assisted reproductive technology, we definitely see statistics that the number of families who are seeking for the fertility treatments is
Mhm.
increasing. Okay.
Mhm.
Is there is a statement that could be done about genetic conditions or anything, or just as we're developing as humans, like
Mhm.
and also, is there is an impact, so some of the arguments, or some of the worries maybe of the people when they're using donor material, right, is just saying, how many siblings we are creating out there in the world, right? And
Mhm.
what would be happening with some communities? Do you see any impact of that through
Mhm.
genetic field? Where you could say,
Yeah.
yeah, you should like opposite. Maybe you're gonna say because we are doing so much counseling, we are so aware, we are also talking about impact. We're actually seeing the number of cases decreasing, or maybe it's even incorrect statement to make altogether.
Yeah, I mean, I think the question is, I think there's a couple parts to that question. I think, it's very important if you are either planning to be a donor or planning to, you're an intended parent, looking for a donor agency that feels like a good fit for you. I think it's important to know that donor agencies' policies. So, is this a program where there's a match one donor to one, recipient? Is this a situation where potentially one donor may be matched with multiple recipients? And if so, does that agency have limitations or have guidelines on, how many times they'll let a donor donate or
Very
something like that. Yeah, so I think it's important to understand each agency's policies and sort of how they handle those processes. Um, I think another point, especially for donors, but for recipients as well. This is like a little different, I think, than what you asked, but kind of got me thinking about this. I think something that is important for these individuals to be aware of is there really, especially now, is no such thing as a anonymous donation anymore. There is certainly de-identified donation, certainly. So if you choose to be de-identified, that is absolutely possible. But I think that's something that is important for, again, especially donors, but also recipients to be aware of, that we can't really guarantee anonymity anymore, especially, with the increase in testing like 23andMe, other direct to consumer testing like that, where, you hear so many stories about individuals finding out maybe that they were donor conceived or, maybe they have siblings they didn't know about. So certainly, and even if somebody does know that they're donor conceived, even if an individual knows that, it's possible that if they did some sort of ancestry testing, they may be able to find the donor um, that contributed gametes. So I think that's just kind of hearing you mention like how is this impacting communities, I think is just something um, I'd love for people to really be aware of going through this process, that we just cannot guarantee anonymity. And I think in the past, that's something that individuals were sort of promised, were guaranteed. Um, and a lot has changed in recent decades, recent years. A lot has changed where that's just really not the case anymore. And we obviously can't go back in time and tell those individuals that. But I think moving forward, it's important that we make sure people are aware of that, and kind of understand that, again, they may not be able to remain anonymous.
Okay, okay, thank you so much.
Mhm,
I have really kind of like just two last questions. And
mhm,
guys, please, for those of you listening, please type in your questions or ask, absolutely, jump in. One question, maybe it's more controversial, I don't know, but for example, in our own programs, and we also have our own medical facilities. Uh, for the programs that we work with, during the prenatal screening, when we're doing, the testing that is mandatory for any potential risks, right? Like biochemical screening, things like that. And then we just lucky that not a single time, I've been, through the cases for over 4 years, right? More like 5 years already. On my watch, not a single time we had a case where the pregnancy had to be terminated. All parents were considering to terminate because of the medical reasons. We had high risk pregnancies, yes, where there was a higher potential for certain risks, but then
mhm,
further it was evaluated. It always goes to the genetics, the reviewing, and by looking at all of the data, it was actually said that we feel a recommendation was that it was good to continue pregnancy, and actually the children that were born, they're healthy, and so knock on
mhm,
wood, everything is well. But I know those kind of cases are being taken so seriously and carefully, because it's a tough decisions for any family to make.
mhm.
In your practice, do you see cases like that where there is additional this kind of counseling, where families are met? And when you do have cases like that, how do you address them? What kind of evidence you're looking for? Um,
Yeah, yeah. I mean, I think, and generally that would be more, it sounds like you're referring more to prenatal cases. So once
yes,
someone is
yes,
already pregnant.
yes, yes.
Yeah. So, I mean, I
I did
think,
not know if it's also scope of your work, but because if
yeah.
families are listening, I really want them to understand what are all of the things that you as a counselor,
Mhm,
right, genetic counselor, you guys could be touching on. So is it a good fit for you to be involved? Is it not? Yeah.
mhm. Yeah, so generally, I mean, I would say absolutely, it's a good fit for a genetic counselor to be involved in that kind of a situation, whether that would be a genetic counselor from a company like GeneScreen, or whether, it would be a genetic counselor maybe working in the practice, the OB or MFM practice, depending on where someone, has established care. But certainly it is something that we do support specifically for clinics that do not have a genetic counselor in-house. I, of course, would love it if every single fertility clinic, OB office, MFM clinic was able to have a genetic counselor in office. I think that would be great. But at this time, that's just not a reality. So we certainly do support those cases. Oftentimes working in, especially in the prenatal setting, we're almost always working in conjunction with the referring physician, but especially in those prenatal cases, we're working in conjunction with the physicians and nurses at the clinic. But certainly those are situations that we do encounter. Maybe that will be someone that had, a high risk prenatal screen,
Mhm.
and it may not even necessarily be someone that went through ART. These could be, spontaneous
Regular
pregnancies as
one. Yes.
well.
Mhm.
Um, but this could be, a high risk prenatal screen. It could be, that someone had something identified on ultrasound or on imaging that they need to discuss further. Maybe it's regarding making a decision, do I do prenatal diagnostic testing via, you know, chorionic villi sampling or amniocentesis, or is that not something that I'd like to pursue?
Mhm.
So for us, it's oftentimes dependent on the situation, kind of where we come in. So that could be, again, prior to any diagnostic testing being done. We may just be reviewing what was identified on an ultrasound, for example. We may be reviewing diagnostic testing results and discussing options with a couple. So it's certainly something that we do, a kind of a role that we can fill. Again, often in conjunction with, the care of a physician too.
Yes, yes, absolutely.
Yeah.
All right. Well, thank you so much. And I guess the last question I have is more like, if you open the veil, what future holds. Is there something that you're saying exciting is coming our way, or some questions that maybe, or problems that your industry is trying to solve, your field? Anything that could be coming the pipeline that you could share with us?
Yeah, I think, there's a lot of potential new testing methodologies and modalities that I think are potentially coming down the pipeline, and honestly are even starting now. I think there's a lot that is still to be explored, though, to be honest, in utility of a lot of this testing. Um, I think a lot of our, and when I say our, I mean, my colleagues, a lot of the maybe concern is the wrong word, but sort of our thought process is what is the utility of this testing? If a patient pursues some of this new testing that's available, um, what is that going to tell them, and what are they going to do with that information? I think is really the main point that we would be focused on when we are potentially exploring, some new test methodology or some new testing that a lab is offering. That's really the first question that we're going to ask. Of course, is this testing validated? Is it reliable? But then again, what is an individual going to do with this information? And what are the potential issues that they may come across when they're making those decisions? How can we support them? Because ultimately, if the testing's out there, people are going to find it and people are going to use it. And it's their prerogative to do so. Our job is really to make sure that they understand the limitations, they understand what that testing is, and that we're supporting them and that we're, assisting them in kind of understanding what those results mean and making decisions. So that's really our goal. So generally, whenever I see any new testing come about, that's immediately where my mind goes is, how are we going to be able to support patients as this testing becomes more commonplace and as they're asking for it with their fertility clinic?
Okay, okay. And if you had a personal dream, what would that be? Personal dream for your
Ooh,
field and for the families in the journeys, what would that be?
yeah, yeah. Oh gosh. Oh my gosh, there's so many. I think accessibility, honestly, is would be I I don't know. I would love it if genetic counseling was more accessible to people, if more people knew about it. I think this field is unique in the sense that patients are more likely to at least have heard of genetic counseling, be somewhat more familiar with it than maybe other fields in medicine where genetic counseling can still be really, really impactful. Um, but still, I mean, there are a lot of limitations with accessing genetic counseling services, with coverage of those services, right? Affording those services, and again, like even finding a genetic counselor to support a patient. Um, so for me, it would really be access to genetic counseling services being more widely available to patients around the world, honestly. Um, I think we're moving in the right direction in our field for that, but still, still a work in progress. And there are a lot of really amazing, hardworking genetic counselors that are working on improving access. Again, not just in this field, but in, many, many fields across medicine. So that would be, my goal.
Oh, well, thank you so much.
Yeah.
You definitely, so I love your dream. I'm smiling as hearing that. I'm in full support of that. And I think many people, that would be listening to you, but thank you for really taking the time
Yeah, of
and kind of
course.
acting on your dream because, today, hopefully you were able to, open like, again, your field a little bit more and explain why it's important, what's the impact and things like that. So I really hope my dream would be that even if one person listens to it, right, whose perspective will be changed and you having
Yeah.
impact on them, that's already a huge achievement, right? It's like, journey at a time, family at a time, and one baby at a time. So this is huge. Guys, if any questions, let me know. But otherwise, I am so grateful that you have been here. And yes,
Yeah. Thank you so much for your time and for inviting me to do this.
absolutely. All right.
Thank you.
Thanks, everyone.
Thank you.
Bye bye.